Thank you very much, Andy, for joining today.
Thank you, and thank you all for joining us.
So I'm going to start with a great question that is sort of more of a general question and not necessarily a question related to the specific PNets. But Dr. Liao, one question from our patients was, what advice do you have for patients who are trying to decide a treatment plan and when they receive differing opinions from different net experts? So I think it's a fantastic question. So,
yeah,
you know,
I think that's a great question. And, ultimately you have to find the right fit for you, in terms of your medical team. But one thing I would highly recommend is to, talk to your doctors and see what kind of setting, how their practice is set up. Many of these centers, net patients are seen by general gastrointestinal oncologists, but their collaborators may not be necessarily net specialists. And as you all know, taking care of net patients is a team effort, and it's a really, really specialized, very focused area. And there's a lot of unique nuances to the management that may not be applicable to other cancers. So I would always advise to seek, consultation at a dedicated neuroendocrine tumor program.
Thank you, Andy. And I would add to that I think like you probably saw from the treatment sequencing panel, there is sometimes no right or wrong, tumors can behave in a very different way, and you may get different opinions, like Andy said, also dependent on the expertise of the net center that you are at. So there are net centers, for example, that heavily favor surgical debulking because they have the surgeons to do this that are very experienced to do this. And then there are some centers that don't. So there are some centers that use PRT a lot earlier. So I don't think there's necessarily a right or wrong. I think there, as you probably also heard from Dr. Chan's talk this morning, there's really a push in the net community to try to understand what the treatment sequencing panel should look like and try to understand what patient would benefit best from what therapy first. And we're just not as far right now. So my advice is ultimately, if you get 2 different or 3 different opinions from 3 different specialized net centers, like Andy said, you really want to go to a specialized net center, then I think it really depends on who you trust the most and what also makes the most sense to you in that particular time of your life. If you plan a major trip, because your daughter is getting married, I'm not sure debulking surgery would be the best way to go right off the bat, right? Because you may be out of commission for a month or 2. So I think there's certain things that you could certainly plan around your life and what you would rather prefer, because again, there's not necessarily always a right or wrong. All right, let's move on to the next. So Dr. Liao, do you consider or do you think that genetic studies are usually helpful in regards to pancreatic neuroendocrine tumors? And what is the likelihood that my children are at risk?
So a small minority of patients with pancreatic neuroendocrine tumors, they have a hereditary predisposition to getting this. So some examples are, MEN syndrome or von Hippel-Lindau and et cetera. And many of these patients have a very characteristic family history. So, multiple family members with other associated conditions. And therefore, for those patients, definitely would be helpful for them to know if there's a hereditary predisposition, because if so, then that would impact the rest of the family in terms of what they need to do for additional cancer screening and things like that. So I would say specifically for pancreatic neuroendocrine tumor, there definitely is a role for doing genetic studies.
Yeah, I completely agree. And I think it's in stark contradiction with small bowel neuroendocrine tumors, right, Dr. Liao, who we are not aware of at least any familial predisposition genes that at least we can test for. Now, with small bowel neuroendocrine tumor, we certainly have heard of multiple first-degree relatives having the tumor, so that kind of gives you a hint that there may be something there, but at least there's nothing, like you said, for example, from like MEN1 or VHL for PNET. I'd also add, I think that MEN1 and VHL is still a very small proportion of the patients we see, and usually they are not subtle. So often these patients have multiple tumors, not just a PNET. And so if there's suspicion, let's say there's very young diagnosis at a very young age of a PNET, or if there are multiple tumors or really multiple relatives in the family that have PNETs, then yes, I completely agree. I mean, genetic testing should be done, but still, I would say, and Andy, correct me if I'm wrong, that a majority of patients with PNETs don't have to worry about that.
Right. It's only the minority of patients who have one of these hereditary predispositions that we know of.
Great, thank you. All right, next question. Will there soon be any new treatments offered for grade 1 or stage 1 pancreatic neuroendocrine tumors? Yeah, so I guess I'll take the beginning of that question, if that's okay, Andy, because it's a little surgical, but I guess it refers to the question of whether we need to intervene in small pancreatic neuroendocrine tumors. As most of you probably know, there are some guidelines from NANETS and ENETS and NCCN that suggest that small, low-grade pancreatic neuroendocrine tumors less than 2 centimeters don't necessarily need to be resected because they have a very slow tendency to grow. The counter-argument to that, of course, as well, didn't any 4-centimeter pancreatic neuroendocrine tumors start with at some point being very small, and I think that's a reasonable argument. I think, as far as I know, there are some groups, even in the US, that are trying to understand which low-grade small pancreatic neuroendocrine tumors need to be resected because they're going to progress to growing and spreading, and which are not. Obviously, the size criteria are a little bit of a crude criteria, but there are groups that are trying to do research and trying to figure out whether there are certain biomarkers, let's say you could do on a biopsy, that would help predict how this tumor is going to evolve over time and whether you really need a resection or not. Anything to add, Dr. Liao, on your end?
No, I think, yeah, that is always the question, when do you want to resect, and when can you just observe? So
and that's, by the way, even truer for patients with VHL or MEN1 that can develop these tumors throughout their entire life in the pancreas. We're even more conservative in resecting them. So Dr. Liao, can PPI, so like pantoprazole, for example, increase chromogranin A, and then the long-term treatment after Whipple surgery? So I guess that's the question. Can PPI increase chromogranin A?
Yes, definitely. I've seen chromogranin A in like 5,000, that kind of range from PPI use, and actually goes back to normal once you stop the PPI. So that's always something to consider. When you're getting chromogranin A levels checked serially, when you see elevated chromogranin A, you also want to make sure if the patient's on a PPI, because that could definitely confound the results.
And then the next question would be, let's see, a pancreatic neuroendocrine tumor, stage 4, grade 1, stable on lanreotide, going on for 2 years following debulking surgery. Is it possible to need nothing else for many years? I guess you can address it, and I'll address it as well.
It's definitely possible. We know that everyone's tumor behaves differently. There's a lot about tumor biology we still don't understand. But that being said, that is the role. That is why debulking, surgical debulking is so helpful, because after debulking, many patients can have very low burden disease and stay very quiet for a long, long time before they need some additional treatment. It can be many years, actually, in our experience.
Yeah, I agree with that. And I think that exactly like you said, Andy, I think that is exactly where, you know, surgical debulking comes in. And of course, the lanreotide plays a role here too, right? Because this patient says that she or he is also on lanreotide. And as we know, you know, lanreotide can also keep the tumor at bay for sometimes even decades, you know, depending on you know, the tumor biology. And again, it comes back to, I think, the treatment sequencing panel that we presented, that where you looked at these two patients with pancreatic neuroendocrine tumors, they both seemed very similar in the beginning, but then ultimately had very different outcomes down the line. And I think that there's a lot more work for us to try to understand how these tumors are going to develop over time in order to be able to treat them properly and really try to understand what the proper sequence would be. So it's an interesting question. So what treatments have been shown to be effective, Dr. Liao, in pancreatic neuroendocrine tumor metastases, which show both somatostatin receptor uptake and FDG uptake?
That's a great
Maybe
question.
You can make that difference between both for those who don't know.
Yeah, so you know, there's many different types of PET scans, and in NETs we use what's called dotatate PET scans, so gallium dotatate and now copper dotatate. But basically, you know, these types of PET scans highlight what's called a somatostatin receptor, which is a marker that's expressed by about, you know, 85% of NET tumor cells. A different type of PET scan is called the FDG PET scan, which is traditionally the type of PET scan that we use for other cancers. And the way this works is basically you get a, you know, a radioactive sugar dye, and it highlights any areas of your body that is taking up a lot of energy. So of course, you know, tumors that are growing, they use energy, so they will light up on this type of FDG PET scan, but so can other metabolically active areas in your body. And so, you know, many of the very low grade, very indolent NETs, they don't grow, proliferate that much, and therefore they don't use that much energy. And therefore, traditionally, what we see is that for the lowest grade of the spectrum, so, you know, grade 1 wall differentiate, that end of the spectrum, typically these tumors are not FDG avid. Whereas, you know, higher grade tumors, so grade 3 or poorly differentiated, you know, carcinoma, these are using a lot of energy to grow. So we typically see them light up very, very brightly on the FDG PET scan. On the other hand, for the dotatate PET scan, we generally see that lower grade tumors tend to have higher expression of the somatostatin receptors, whereas higher grade tumors and poorly differentiated tumors tend not to express somatostatin receptors, and therefore lower grade tumors tend to light up on dotatate PET scan and not on FDG PET, and on the other hand of the spectrum, higher grade tumors tend to light up on FDG PET and not on dotatate. Now, this is a spectrum, therefore in the, you know, in the middle of the spectrum, there will be tumors that can actually light up on both. And so what that means is that, yes, they still have the somatostatin receptor and they can still potentially benefit from treatments like somatostatin analogs or PRT. However, the fact that they also light up on FDG PET tells us that, you know, they're perhaps a little bit more aggressive in biology compared to those that don't light up on the FDG PET. And so in terms of our treatment options, you know, the ones that rely on the somatostatin receptor are the somatostatin analogs. You know, they bind to the somatostatin receptors, and also PRT also, you know, relies on the somatostatin analogs. So for patients who benefit from those, you know, they generally need to have the somatostatin receptor expression. So, but there are many other treatment options available. So, you know, there are targeted therapy options such as everolimus and sunitinib that are approved for pancreatic neuroendocrine tumors. There's traditional chemotherapy like capecitabine and temozolomide, and many others that are being developed. And you know, all of these, as far as we know, are for all comers. So, you know, it doesn't really depend on the somatostatin receptor expression. So that's a long-winded way to answer your question. But basically the short answer is that some of the treatments we have rely on the somatostatin receptor, and therefore for those treatments, you definitely need to have somatostatin receptor expression on your tumor for the treatments to work. But many other treatments, such as capecitabine, temozolomide, everolimus, and sunitinib, don't rely on that, and therefore can work on tumors that are both FDG avid and Dorothea avid.
Thank you, Andy. Yeah, I think my take on this is exactly the same. I think if I would have someone that comes with an FDG uptake and a somatostatin receptor or dotatate uptake, my suspicion, like you mentioned, would be that perhaps it is a little bit more aggressive. But on the other hand, we have not studied on a large scale everybody that has positive somatostatin receptor uptake on dotatate also with an FDG PET. So you know, if you have uptake in both, again, it doesn't necessarily mean that your tumor is more aggressive. It could mean that, but we don't know that for sure. If there's no dotatate uptake, but there is FDG uptake only, like Andy suggested, that would definitely suggest that it's more on the higher order, more rapidly growing spectrum. So one more thing I would add is, I think it depends on the percentage, right? I mean, if you have only a small percentage that's FDG avid, but a large percentage that's somatostatin receptor avid, perhaps like Andy suggested, therapies that target the somatostatin receptors are really good for you. If it's sort of 50-50, then you know that if you give PRT, 50% of the tumor is not going to be treated. That may not be the best option. There may be something like CAPE-10 or something else would be a better option. But I think it's a really interesting question.
Yeah, it's a very interesting question and a very good question. The other point to add is tumors definitely change over time, and you can see like more heterogeneity over time. So for instance, you know, patients who've had PRRT and chemotherapy and everything, you sometimes see different clones of tumors emerge. And so, you know, some are better behaved clones that stay quiet, but some are more aggressive clones. And sometimes we even try to re-biopsy these patients, you know, their disease is not behaving how it used to be, because sometimes tumors do evolve over time.
That's a very good point. As a reminder, we have 5 more minutes. So if you have any questions you'd like to ask, please put them in the chat box here. I'm not sure. Let me see here. I just want to make sure that I'm seeing questions if they do pop up. But please ask your questions if you'd like to. In the meantime, we'll just move on. That's a great question too. How can PRT be improved for the treatment of pancreatic neuroendocrine tumors? With perhaps drugs approved for NETs? What do you think, Dr. Liao? How can we improve PRT?
That's a great question. I think there's a lot of, a lot of rationale, like scientific rationale, to explore combination therapies. So you guys may have heard of the Australian study looking at PRT combined with CAPE-10, and even though the response rate was a little higher, it was significantly more toxic in terms of low blood counts and things like that. But we know how PRT works, you know, and especially in pancreatic neuroendocrine tumor, there's perhaps also rationale for combining PRT with other new classes of drugs that are used in other cancers. For instance, drugs that target what's called a DNA damage repair pathway. So PARP inhibitors, for instance, used in breast cancer, ovarian cancer. So there's a lot of scientific rationale for this combination. So that's one example. And the other is that, you know, we know that PRT is a type of radiation, and there's also scientific rationale for combining radiation plus immunotherapy, that it may make the immunotherapy work better, as shown in other diseases. And so that is another combination that's being tested. And there's many more that are more ideas that are coming to fruition in terms of being developed into clinical trials.
Great, thank you. We got 2 minutes left, so a few more questions. So what are the recommended therapies to treat neuroendocrine tumors, pancreatic and gastrointestinal, with miliary seeding in the liver? So if you don't mind, I'll take that one, Andy. So by miliary seeding, we mean that when you do a scan, you see several really, really tiny lesions in both lobes of the liver. And the radiologist sometimes quantifies them at innumerable. Innumerable is a term that I personally don't like, just because of the fact that sometimes it's just 20 or 25 lesions. That's not innumerable. I think you can count that. But obviously the radiologists also have a lot of things to do, so they can't spend all day counting 95 lesions. But they are really those livers that have, 50, 100, 150 really tiny tumors all over the liver. And I would say that here, surgically, that's not a good option, because these lesions are often too small for me to find in the operating room. There's just too many for me to remove. But if you clump them all together, this may still represent a significant amount of tumor volume compared to the healthy liver. So that is sometimes a challenging situation. And, depending on where you are along the course of your therapy, things like liver-directed therapy with our IR colleagues, so shooting beads in the liver, preferably non-radioactive beads, just regular beads to stop the blood supply. Therapies like PRT, right, ND, that sometimes work really well for small tumors, maybe even better for smaller than for larger tumors. Even chemotherapy, depending on whether there's only disease in the liver or whether there's disease all over the place. I think that will sort of direct whether you're going to go towards the liver-directed approach or whether you're going to go to the more systemic approach. But there are still a lot of good options to treat patients with biliary disease. Coordinator here saying that we are unfortunately already out of time. So this was very quick. Thank you very much for submitting those questions. I hope this was helpful to you. And please go back to the main conference website where the meeting is resuming at this point. It's good to see you, and thank you, Andy, for being here today with us.
Yeah, thank you all for joining us.